Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is Mastering Mercury, Part 3, Interpreting Quicksilver Mercury Tri-Test. My name is Christopher Chu, and I am the Director of Marketing for Avexia Diagnostics and will be your host for this webinar. Today, I have the distinct pleasure of being joined by an exciting guest, Dale White, who will be our presenter for the webinar. Dale is a California state licensed acupuncturist with over 40 years of clinical health care experience in bodywork, nutrition, herbal, homeopathic, acupuncture, and functional medicine studies. He has worked in a variety of clinical settings, including halfway houses for mentally ill, AIDS clinics during the epidemic, a hospital chronic pain clinic, as well as private practice. In 2015, Dale joined Dr. Christopher Shade as a clinical consultant for Quicksilver Scientific, providing physician education on test interpretation, products, and protocols. Without further delay, I will now turn the webinar over to Dale.
Hello and welcome to Mastering Mercury with Quicksilver Scientific, a three-part webinar series with Dale White. That's me. I have been a clinical consultant with Quicksilver since 2015. This is part 3, Interpreting Quicksilver's Mercury Tri-Test. Mercury Tri-Test is patented, and it uses highly sensitive testing methods to show the concentration of both forms of mercury that we talked about in the first two parts, the methyl and the inorganic mercury. Both of these forms are circulating in the blood, and hopefully they're being excreted through the liver and kidney. This is an overview of the test. The report. It's 2 pages, and the first few times, please read the second page, or if you forget anything or need to clarify anything, probably the answers you'll find on the second page. But what you're mostly concerned with will be the first page. And here is, and you can see where all the different information is, and you can come back to this slide, but you're probably not going to need it. It's pretty straightforward, like most reports, but there may be a few things that you forget about or need to clarify the first few times. So first, we're going to talk about the blood results. Mercury Tri-Test is called a Tri-Test because we're taking blood, urine, and hair samples. And what you're going to see on the top half of the report, which is the blood results, the table that will be in the center of the page, that has the numerical results of the blood concentrations of the methyl and inorganic mercury. And then the bottom row in the table will be the total mercury. That's the sum of the mercury, methyl mercury, plus the inorganic mercury. And you'll see these gray bars above on each of the colored bar graphs. Those gray bars represent the Quicksilver average. And on the bottom colored bar graph, that's mostly different shades of blue, you'll see a white bar. That white bar is the CDC average. When you get a result back, the dark blue bar will be the patient's current results. And if you have a follow-up test, the gold bar will represent the previous results. And then you see those in the bottom here in the table in that column of the test results left. You see the current results, prior results, and the percent change. So Mercury Tri-Test is the only test in the world that speciates or separates these different forms of mercury, methyl mercury, and here you see it represented in the top row of the table and the top colored bar graph. Inorganic mercury is presented in the center row of the table and the center colored bar graph. And then the total mercury is the bottom row and the bottom colored bar graph. Make a note here that the CDC average, so in that bottom blue colored bar graph, the CDC average represented by the white bar is different than the Quicksilver average, which is represented by the gray bar. That's because the Quicksilver results are from a pre-selected group of people who are presupposing mercury toxicity. So, of course, those averages are going to appear higher. So here are reference values for methyl mercury and inorganic mercury represented by the patient data generated by over 9,000 tests from Quicksilver. And the reference value for the CDC is different. Here you see that difference again. Gray bar, Quicksilver average, white bar, CDC average. This percentile view is one way to evaluate the severity of the methyl and or inorganic mercury toxicity in the blood relative to the percentile. And you will see this presented on page 2 if you forget about it. However, we can be a little more specific with regard to each form of mercury. So let's look at methyl mercury toxicity ranges. So we are exposed to methyl mercury by ingestion as it comes from our diet. In almost all of your cases, 99.5% of your cases, methyl mercury will be present in much higher concentrations than inorganic mercury. It's typically the most dominant form of mercury. So these are another way to look at how we might think about toxicity of methyl mercury. So in the top row here, you see expected. Mercury is it's ubiquitous in our environment. We can't escape it. So we do expect everyone to present with a small concentration of methyl mercury in their blood. We would consider this normal or expected. We want to see a little bit of this in the blood because it means it's in circulation, so it can be excreted. For methyl mercury, borderline is around 3. So depending on the patient, that may or may not present a toxicity issue. If somebody's pretty hardy, 3 might be okay. If they're pretty compromised, we might want to keep it under 3. Mild to moderate, you see that up into the tan zone. Moderate to severe into the pink zone. Anything in the red zone we would consider severe. Now let's look at inorganic mercury toxicity ranges. The primary source for inorganic mercury is mercury amalgams, and that's vapor coming off of the amalgams. We inhale it into our lungs. We take up about 80% of it, and then it spreads to our other tissues. Here are some what we might expect from inorganic mercury. Again, the percentiles are going to be pretty similar to methyl mercury. But if you look at the actual concentrations, you'll see that inorganic mercury is scaled on a much tighter scale than the methyl mercury. And this is because inorganic mercury is much more highly toxic in small concentrations. So again, we do expect to see a small concentration of inorganic mercury present in the blood, which means it's in circulation and can be excreted. Now, borderline to mild is a little bit different with the inorganic mercury. We really don't want to see this inorganic mercury extending much beyond the Quicksilver average, the gray bar. So we want to keep it under that level, and then moderate, moderate to severe, and severe. Okay, this is the part that most people have a little difficulty with. So reading the urine and hair results, the excretion profiles. So the urine and hair results table is located in the lower right-hand corner of the first page. On the left, you'll see that there are the 3 rows, again, methyl, inorganic, and the total mercury. The middle column is labeled urine results. And this is this column has 3 subcolumns, the current, prior, and percent change. The hair results are presented in the lower right-hand corner, and you'll see that these, it will only be listed in the total mercury, and this is because what you're seeing in the hair is methyl mercury and an insignificant amount of inorganic mercury. So we just list it as the total here. Urine, hair. The urine is excreted by the kidneys. And what you see here is that what's excreted by the kidneys is almost exclusively inorganic mercury. Remember, in the blood, methyl mercury was the most dominant form. The kidneys are filtering the blood and excreting urine. And what you see in the urine is by far inorganic mercury. Very little methyl mercury. So let's look at excretion. Excretion pathways. Inorganic mercury comes in through the vapor, excreted through the kidneys. Methyl mercury comes in through the diet, excreted by the liver into the bowel, into the stool. So these are the excretion graphs on the lower half of the first page. And these represent the excretion graphs of the liver and kidney. They're constructed using data points from the blood, urine, and hair. So think of the liver and kidneys as filters. And what we want to do is evaluate the efficiency of those filters. Blood concentrations of mercury are plotted on the horizontal axis, and the excretion products on the left, urine, plotted on the vertical, hair plotted on the vertical. The diagonal black line here represents average excretion. When we get our result, we want to see that dot fall on or above that diagonal black line. We want to see it on the line or in the white region. If we see it in the red region, then we know we have a compromise of excretion. So when we make these graphs, what are we measuring? What are we evaluating? Excretion is a function of transporter dynamics. Metals are transported into and out of the liver cells via these transporter proteins embedded in the cell membranes. The primary exporting proteins or excretory proteins are called MRP2. That's multi-drug resistant proteins 2. Here you see this in the kidney, MRP2. Here you see it in the liver, MRP2. So, and notice that what's being excreted in the urine is inorganic mercury, and what we're excreting in the liver is primarily methyl mercury because that's the most dominant form in the blood. Excuse me. So here's kidney excretion. This is the kidney excretion graph. The labeling, if you forget, the labeling of the graph will remind you. So you up here, you see urine results. Obviously, that's kidney. Indication of inorganic mercury excretion ability. So that's telling you that inorganic mercury is being excreted by the kidneys into the urine. The blood concentration of inorganic mercury is plotted horizontally, and the excretion product, in this case, the urine, vertically. Average excretion means that your kidneys are able to excrete inorganic mercury efficiently. And once the source of that mercury exposure is removed, the blood concentrations will decrease over time. Below average excretion causes the patient to retain mercury. We call that retention toxicity. The rate of exposure, if the rate of exposure does not decrease, then mercury will accumulate. If they keep taking it in and they can't get it out, it's going to build up, it's going to accumulate, and that's retention toxicity. So you have to have proper excretion and elimination for these toxic levels to be reduced. The graph is scaled so that the diagonal black line represents an average excretion ratio of 6.9 in the urine to 1.0 in the blood. And that will be described in the little legend box in the lower left-hand corner of page 1. So here you see urine, inorganic mercury. Here you see blood, inorganic mercury. So let's look at liver excretion. Same concept. Here we have hair results. Now, the excretion product of the kidney is urine. That's obvious. The excretion product of the liver is bile, but we can't get a sample of bile so easily. So we use hair as a surrogate, and it works pretty well. It's not as direct, and it's not as timely as urine because hair grows over time. So there's some exposure to elements, but it works pretty well, and we have some papers to back that up. So you can see here, hair results, indication of methyl mercury excretion ability. This is the red and white graph on the right-hand side of the lower half of page 1. And we are plotting, again, blood horizontally, hair vertically. This is the average excretion as described by the diagonal black line. Below average excretion causes the patient to retain mercury. Again, it's called retention toxicity, and we need to establish that proper excretion in order for the mercury to be eliminated and for our protocol to be effective. In the top row of the table, you see the blood result. And in the bottom right-hand corner of the table, you see the hair result. Blood plotted horizontally, hair plotted vertically, and the diagonal black line represents a ratio of 375 in the hair to 1 in the blood. So let's take a look at a case study. In this case, this is a fairly extreme case. You may see a few of these, but this case represents some of the concepts very well. So let's take a look at this. Case study, 56-year-old CEO, heavy fish consumption. So we know there's going to be a lot of methylmercury. The amalgams were removed many years ago, so we would not expect much exposure to inorganic mercury. This patient has early onset dementia, anxiety and a racing mind, fatty liver and insulin resistance. Initially followed functional neurologist supplementation recommendations, which helped with some of the symptoms, but not very much overall. So here are the initial mercury tri-test results. Again, you won't see many cases this high, but I've seen them actually higher, up in the hundreds. So you can see that the dark blue bar is well into the red zone, representing a severe toxicity. Remember that from our previous trainings that this patient had no amalgams, so no exposure to inorganic mercury from amalgam. However, when methylmercury gets up into this pink and red zones, it's concentrated enough to convert to the inorganic form. So that's the source of the inorganic mercury here. It's not amalgams, it's a demethylation of high concentrations of methylmercury. So how well is this patient excreting the two different forms of mercury? We can see poor excretion, poor kidney excretion of inorganic mercury, leading to retention, and poor excretion or poor bile clearance of the methylmercury, leading to retention. This is the follow-up test. So here you can see the gold bar represents the prior test result, and the dark blue bar, the current result. We can see that both forms of mercury came down significantly, but there's a little more work to do. So there's the original test, the gold bar, the follow-up test. So here are the follow-up excretion profiles. We can see that both kidney and liver excretion have improved a lot. Restored kidney clearance of inorganic mercury, and good bile clearance of methylmercury. So in this case, we saw a 91% drop in methylmercury, an 80% drop in inorganic mercury. We saw the excretion markers corrected. We saw, and in his blood work, the liver and blood sugar markers normalized, and memory and other neurological issues were vastly improved. So we can infer from this that the patient's fatty liver and insulin resistance were significantly impacted by the mercury toxicity. Okay, thank you for attending this three-part webinar series on mastering mercury with Quicksilver Scientific.
For any questions or issues you may have, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dale, for this informative presentation. Thank you again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Quicksilver Scientific, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.